Hello and welcome to the December 2025 LLR LMC podcast. Today I'll kick off with just letting you know that we had our last meeting of 2025 of the LMC board on the 10th of December that is. Gangzu represented UHL. Gangzu is the new medical director of UHL, replacing Andrew Furlong, who has now retired. As well as him, we also had Dr. Ru Abiratney, who is a consultant in old age medicine, but is also leading on the neighbourhood health service schemes on behalf of UHL. And we had a long conversation with her about the opportunities and threats for both general practice and the hospital regarding this, including if an IHO were to appear, if that was hosted by either UHL as the acute trust or even possibly by the partnership trust. Just as an aside, I did have a one-to-one also with Richard Mitchell separately, who couldn't come to the board meeting, where we also discussed that, and I made it very clear that from general practice's point of view, we would expect to have parity on any decision-making body regarding an IHO, because the IHO would hold the budgets for all parts of the health service, including general practice. And as I've mentioned in previous newsletters, this puts us at a huge risk, because in the past where budgets have become single and joint like that, what we've found is that the money has flowed from primary care into the acute trust, and we know that we mustn't have that happen again. So the next thing is just to mention open safely. I mean, hopefully your practice has already done this, but this is mandatory. And also the profession likes open safely. Open safely was invented during COVID, and it's a way of sharing data nationally from general practice in a safer, controlled manner. So the Joint Committee for General Practice IT, which is jointly chaired by the Royal College of General Practice and by the GP Committee of the BMA, have a say in what extractions and processing can happen using this. So we want this one to work, actually. So if you haven't signed up to it, please do so. As an aside again, a little bit surprised that this is mandated, and unlike everything else which is mandated, where NHS England seem to go out of their way to do it and also put huge pressure on the ICB, they haven't. Although since I started writing this newsletter, I noticed that they have sent out one email to all practice just to remind them that it is actually a legal requirement to sign up to it. Next thing just to mention, as you may or may not know or remember, when I first came in as chair of the LMC, one of the things I was keen to do is to try and focus on some issues that are annoying to general practice, but due to various problems have never been solved. So those things that we knew would take a lot of time, a lot of pressure. We've achieved everything that we set out to achieve. The only thing that we haven't done so far that was on our list was the download button on ICE. So this is SunQuest ICE, a button which allows you to download, say, an investigation which has been done by another body like UHL or another service, but it's on ICE. You can then look at it, click on the button, and it will download it. But it will download it using the same process, which at the moment is using the artifact message and path links onto your system, so it will come down in a coded way. This is going live soon. It's going live just before actually Pathlinks and Edifact is going to be replaced. The Edifact message I worked on in the 1990s, that's how old it is, but is now going to be replaced by a system which is using FHIR, which is an interface process, and something called PALM, which is pathology, library of medicine, I think. Anyway, so it's going to be replaced with a system which is fully SNOMED CT compliant, which will mean that more coded results will be able to be sent down to practice in the future. Next, just to mention NHS Mail. Now, again, this was a project that I worked on. I was one of the few people that worked developing the original NHS Mail. You may have noticed that it's been renamed again to NHS.net Connect. I don't know why. NHS Mail to me sounds a lot better and trips off the tongue better, but never mind. But just a reminder, although we publicise it as being an email for life, because when we designed it, one of the things I insisted on is that the email address should follow you around and shouldn't be static to the organisation that you're in, and it should also support you working for more than one organisation. It's for your work life. And the other thing, it is a work email, and like every work email, it can be opened by your employer or the equivalent. Now, there are checks and balances to this, but recently there's been a few cases where this has happened, and on one case, a salaried doctor, not within an hour, but salaried doctor approached me for my advice and knew my interest in it. I just had to say to them, if they follow due process, which appeared like they have, then they can do it. But of course, what's happened is that doctor at present does not have access to his NHS email, which is, I suppose you could say, fine for work if you're not going to work, but he was using it for other reasons, for sign on for other sites, and for sort of storing contacts and things which were not NHS related. So don't use it for personal use. Do get another email address for that. I've been using something called mail.com, and they've recently started a new domain, dr.com, and look at it, there still seems to be loads of those. So they might find an easy one. You can have the free service, or you can pay for the enhanced service. I do pay for the enhanced service, which is about £3 or £4 a month, which allows me to use through Outlook, which makes life easier for me. And as I say, I got it earlier, and so my address is gji@dr.com, which of course matches my NHS address, which is gji@nhs.net. Next item, LHIS. We've been getting various sort of complaints about how LHIS, we've had problems with them charging for things that they shouldn't have done, like peripherals, worn out mice and keyboards and things like that, which they're not allowed to do, but also the quality of their service, and forcing practices to buy new kit without any attempt to repair what is already there. We haven't really got enough to make this a formal complaint yet. LHIS is commissioned by the ICB, so it's the ICB that we'll be talking to. And so if you have got any concrete examples of things like this which has happened to you, or any other problems with LHIS, please let me know. LHIS, I've actually found that their call centre has been really helpful recently in sorting out a few problems I've had. But we've also had problems with getting them to replace kit for my own practice. But just send us examples, and I'm sure we can sort it out. Next thing, just to confirm, as per our previous couple of newsletters, that Bluestream, the LMC has agreed to pay for and is in the process of going through the contracts for a 3-year period commencing from the 1st of April 2026. And just while we're talking about training, just to confirm that the ICB advises that face-to-face safeguarding and Oliver McGowan training will continue, but they will no longer support any basic life supports training or training regarding vaccinations. So those practices will need to source for themselves in the future. Next thing I wanted to mention was OPAL reporting and the Director of Services, or DOS, RAG rating. Now this has been raised by a few practices where they have OPAL reported because they basically, for whatever reason, they can no longer function, can no longer provide any further capacity, and they've advised this to the ICB, and as per previous LMC guidance, they requested their RAG rating on the DOS to be changed, but the ICB has changed this to orange or amber and not to red. Red is the one which tells 111 that you are full, you have no capacity, so please don't send us anyone else. Orange just says to the 111 and other services that you're getting short of capacity. So that is obviously the wrong thing to do, and personally I think that that is a patient safety issue. And we have requested the ICB to change that, but in the interim, if you do need to over-report because you've reached capacity, thought something's happened, and my own practice had to recently do it because we hadn't been able to recruit a local for whatever to replace a missing partner, and another partner went off sick at the last minute on a Monday, and by mid-afternoon we just had, we had no capacity. I was duty. I had slotted in lots of extra slots. Hand up well over my 25, but we were booked out for the rest of the day, so at that point we did over-report. So please do that. Please ask them to change the reg rating if they don't respond appropriately, and then please first of all contact them again and ask them why they haven't changed the reg rating to red, and also advise the LMC. Thank you. Next one is just about for information. There is a local shared care record. This has been coming for a long time. I know actually in their stuff they say it started in 21, but it wasn't, because in 2018, when I was still involved nationally at IT, I remember meeting with NHSX, one of these many organisations that have been rolled up into NHSE now, who were concerned about some of the earlier shared care records, which they thought weren't complying with the UK GDPR, and we worked with them about sort of trying to work out guidance and frameworks for localities use. Anyway, so the local system has gone live. It scoops up information using GP Connect from practices, and then it displays that joined with information from the hospital, which includes discharge letters and appointments and things like that, and from social services together in one place, and can be accessed by anyone who is directly dealing with that patient, and that includes anyone within health or social care. Now, just to say that the opt-out model, because this is considered to be direct patient care, they are assuming or relying on implied consent, which they're legally allowed to do. So the what's called type 1 opt-out, which is the one which patients can sign up with you, which stops data leaving the practice, or the national data opt-out, or type 2, which stops data held nationally from being used for third-party things like research, don't work. So there's a separate opt-out. Now I'm challenged this slightly, because actually they say to opt out you have to either email them or to phone them. So there is no simple way of opting out. I've not tried it. If you have, or you know someone who tried, please let me know what experience they have, because I have a feeling, looking at some of the literature, that their response will be to try and persuade you not to opt out. So if you want to opt out, and you have a problem with that, or if you have a patient who's tried to opt out, then do let me know. Within the article, we have got some background information that you can read, which is hosted on our website, but also there's some downloadable stuff, including leaflets and posters produced by that service, that you might find helpful. Next, for city practices only, just to say that the ongoing saga about the revised contract for health checks continues. They've had to modify it slightly again. They've actually reduced the requirement, so they've dropped the requirement to provide lots of detailed information about practice finances. You'll be pleased to know. So please look at what you have to do. And if you log on to their hub, you'll see the new revised sort of questionnaire, which has dropped all those questions. They're still planning to hold support, which they say is going to start from 24th of December. So I don't know if they really mean that the first day is going to be on Christmas Day, but we'll wait and see. And for those in accountancy, if you're thinking, thank the Lord we've got away with it, this is a change in the procurement law. So the Leicestershire County Council will have to change their procurement process with practices for health checks as well. We have tried contacting. We've got no idea where they are with it. I think they might even be sort of sitting back and seeing what's going to happen with City before they go ahead. Coming towards the end now. Google reviews. Now, we all hate these. Someone brought to our attention at last board meeting that schools are ganged up together and have managed to get schools not to be included in Google reviews. So you cannot Google review a school anymore. We feel that actually general practice aligns very much with schools, and we want to think about how we can start a campaign to try and get Google to change this. So this is just sort of letting you know that this is going to be on our list of things to achieve next year. And I suppose we could actually say that we'll add it to our can we fix it, because this really ought to be stay on our radar until such time as we have exhausted every possibility and hopefully have achieved the goal. Coming to Christmas and New Year, I hope that your practice has signed up to subcontract and has notified the ICB regarding this from 4 o'clock on Christmas Eve and New Year's Eve. Within the newsletter, we just reiterate that the things that you need to have in place for that to go ahead smoothly. I've written a little Christmas carol, LMC's Christmas carol, with huge apologies to Charles Dickens, and I plan to do that as a podcast as well. So if you're really bored, if you need something to lull you to sleep in the evening, please listen to that. And then finally, to wish you all a Merry Christmas and a Happy New Year. There is an ancient Chinese curse which says, may you live in interesting times. We have definitely been doing that through 2025, but I hope in 2026 things settle down for general practice and the NHS. But we have but hope. So catch up with you next year in 2026.